Welcome to our talk on preparing a clinical support model for silent mode in general internal medicine. My name is Brett, and I'll be presenting on behalf of collaborators at the University of Toronto, Unity Health Toronto, Vector Institute, and the Hospital for Sick Children. We seek an early warning system for the general internal medicine unit that alerts clinicians if a patient will have an adverse event within the next 24 hours. These adverse events are defined as an unexpected death, transfer to the ICU, or issuance of new palliative orders. Clinicians request that there are no more than 2 false alarms per true alarm. This roughly corresponds to a positive predictive value of zero point 0.4. We ensemble 8 independently trained models that are a combination of generalized additive models, LASSO, GRU, and GRUD, trained on various modalities and subsets of features. During validation, we modulate the individual model thresholds so that when 3 or more models vote simultaneously, we obtain a positive predictive value of zero point 0.4 on the validation set. In the end, the ensemble is tested on a held out perspective test set in pink. When we simulate the deployment of this model, we see that the positive predictive value remains near zero point 0.4 on the prospective test set. We also show the corresponding sensitivity for the chosen thresholds. However, the reporting is slightly more nuanced. While we formulate our task to raise alarms within 24 hours of an adverse event, we see that more than half of our true positive alarms happen before 24 hours. You can somewhat ameliorate this by reporting on a per stay basis rather than a per window basis. This means that if a patient receives an alarm at any point before they experience an adverse event, it is considered a true positive. This increases the appearance of the sensitivity and positive predictive value of the model. However, neither aggregate metric shows how many alarms are truly actionable. We also observe the performance changes depending on how long the patient encounter is. If a patient is discharged or experienced an adverse event in the first 4 days, we have a higher PPV at the expense of sensitivity. For patients with longer stays, we detect over half of them who at some point in their stay will experience an adverse outcome. Finally, we look at the clinician alarm strategy. Under the regular alarm strategy, we received 29 true positives in our test set. This corresponds to 1.28 alarms per true positive. We also experienced 12 false positives, corresponding to 1.25 alarms per false positive. When we add an additional requirement for an extra vote in the first 30 hours, as well as a 24-hour silencing period after the first alarm, we can enrich the alarms per true positive while simultaneously decreasing the number of alarms for false positive patient. Thank you for listening to our talk, and please read the full paper for expanded commentary.